Wearing red today.
I'm not wearing red. I'm not wearing red.
We apologize. Welcome to Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. And it is technically Go Red for Women Day and Heart Month. And Dr. Martinez is out of the country right now, so we'll forgive him for not wearing red today.
Thank you. Thank you. Thank you.
Good morning, Matt. Tell us where you are and what are you doing?
I am in Zurich, Switzerland, so 6 hours ahead of you. And we are updating the cardiac evaluation process, player health and safety for FIFA. We're in the headquarters for FIFA, so excited to be here to deliver it from the heart of global soccer.
Global soccer. I was going to say, for those non-sporty people, what is FIFA? But it is the professional soccer organization.
Yeah, they run the World Cup, right? So this is what's coming. It's going to be an exciting time coming up in the next few months. So we're excited to be a part of it.
Especially like the Jersey connection. We've got front row seats this time.
MetLife final. You got it.
Oh, gosh, that's going to be a lot of traffic. That's my Jersey way of thinking about things. So it is Heart Month. It is also my 9th Heartiversary week. So 9 years with Brandy. Almost unbelievable. It is Go Red for Women Day. So we got a lot of slogans for today.
And 30 years of HCMA.
And it is our 30th anniversary month. So, wow, there's a lot going on. And I find this a challenging time because we're honoring, representing, drawing attention to heart health and the cardiovascular community as a whole. And, some of us have a pretty mixed relationship with this field, right? We don't necessarily want to be here, and we are here. And it's kind of mixed emotions to celebrate Heart Month, or is it honor or mourn for some? So that it has a lot of mixed feelings for people, especially me. I don't know if anybody else feels that way, but it's poignant to take the time to remember those who aren't here anymore and also celebrate the advances to keep families whole longer. So it's one of those mixed days for me personally.
Yeah, I agree.
So Matt, since last we spoke, what do you think is the hottest news in HCM?
Yeah, well, I mean, the hottest news for me is that aficamten is rolling out. We are now able to, aficamten or Mycorrhiza, we're now able to offer this as a second-in-class option for medical therapy, another type of cardiac myosin inhibitor, like we have with mavacamten and Camzyos. But now we have two, which I think serves us in multiple ways. Offers patients choice. It brings ongoing, notoriety is the wrong word, but exposure to the disease and medical treatment options. And again, marks a disruptive technology that has been patient-centered and a marked improvement for patients. So we're excited about how to engage that and how we're going to roll that in our own practice. We've started using it already. Super excited to have that part of our tool belt.
So it's going to be rolled out I think it's next week, the 17th. So 10 days, 11 days from now, HCMA will be holding a webinar with Cytokinetics, and we're going to bring everybody up to date on what they need to know about the label and what they would need to do to engage with their clinical team to see if this is the right option for them. We've been getting a lot of interesting questions, and we've been filtering them back to Cyto. So hopefully they will have the opportunity to prepare some answers to the questions that you've already been asking us. But do join us live. You will have the opportunity to ask live questions. And if they're able to answer it live, we will do so. If we can't answer them live, if it requires additional research, we will be doing that and getting back to you after the webinar. So please do sign up for the webinar, and we'll be dropping lots of notices about that next week, and you'll not probably miss it, I hope.
Yeah, I think lots to learn about it, lots to learn about the process and how it rolls out. And but I love that we've got another option for patients to talk about what fits the patient need as it should be.
So we have Mycorrhiza, we have Camzyos, but we also have some upcoming clinical trials that are out there and some other methodologies, whether it be RNA silencing or AAV9 gene therapy or another molecule. There's a lot of other things happening in the HCM ecosystem, not only on therapeutic options, but global awareness as well. So there's just a lot going on right now, Matt.
You got it. And as you said, there are more coming down the line, clinical trials. What I love about this is that now when you meet with a center of excellence, they provide you with those options. So, it's a little bit self-serving, but as you think about centers to go to, the reason to at least go to one once, in my opinion, is that they can give you all these discussions. Is this better for you or is that better for you? And as the patient, you get to decide. So you have an expert who explains all those options, make sure that everything is covered beyond obstruction, right? Sometimes I have to remind people that managing obstruction and symptoms is important. It's just one part of it, right? Sudden cardiac death. How do we handle genetics? How do we handle exercise, nutrition, and the rest of the story? So those are the 4 pillars we talk about, but that's where you gain this from going to a center of excellence and engaging, in a partnership, center of excellence with whoever your primary cardiologist is.
Absolutely. And as we go into HCM Awareness Day at the end of the month and Heart Month, and we think about clinical trials, and we think about our hearts a little bit more in February than we do at other times of the year. So this is a great time for people to just say, okay, what do I have to do for my heart right now? What's out there? And part of the reason you see behind me, we have some new posters that should have arrived in your office at some point.
I got
So
it.
you put them up and just get people to talk about what is a center of excellence? Why do we come here for care? What is the benefit of a multidisciplinary approach to treating my hypertrophic cardiomyopathy and making sure I'm not missing any new treatment options? So we are super thrilled to have this day come up and start talking about it a little bit more in depth and sharing the personal journeys along the way.
Yeah.
So I typically do this during Heart Month, and I don't remind you that I did it to you last year because you always look at me and like, oh, you didn't prepare me for that one. But these are the best conversations. It's HCM Awareness Day. It's Heart Month. Thinking back at some of the most memorable cases, obviously de-identified, what are some of the most challenging things as a clinician that you've had to face dealing with complex HCM? And what's that story that stays with you?
But the list is long.
You could pick a few.
I think the early days when we started using myosin inhibitors for me now, there are lots of them, right? We have transplant patients that are now going on doing booming things on the internet, and they're talking about their own experience and they're exploding it, right? And bringing people in. We've got, benefits of sudden death awareness where they've gotten a defibrillator and shocked and lived to tell that story. But I can't help but notice the benefits of now having 3 to 5 years of experience with Camzyos and watching the lives change on folks who say, this has been a dramatic change for me. I didn't know how bad I felt until I felt better. I think that's been the key for a lot of folks who are a little reluctant to try Camzyos, and it has been life-changing. And there's nothing better for me when the patients say, thank you for making sure that I did this safely. Thank you for introducing me to this. And I've never felt this good. I do more than I've ever done before. My life is back. Talk about sudden death. We talk about family screening, but giving someone their own life back where they can now spend time with their family members. They can go to the beach. They can go on hikes. There's nothing better. And there are too many of those individual stories, but literally hundreds in the last 2 or 3 years of folks who have been altered. And for me, it's what brings you back, right? It makes you work on the weekends and stay late and add on patients and all the crazy stuff we do. That has been life-changing for sure.
Is there any, got a little echo there. Is there any cautionary tale that makes you stay on your toes and remind you how tricky HCM can be?
Oh gosh, yeah. Unfortunately, there's a very it's now famous. It's somewhat famous in the Jersey area, of a young wrestler who was low risk, had no high risk features, and on a day he was not wrestling, was at a friend's house, thankfully, and he had cardiac arrest in their basement, and then ended up getting shocked by his friends did CPR. They shocked him, and now he is back to normal again and doing incredibly well. But humbling for sure, right? That we still have a lot of work to do to understand the disease, but low risk does not mean no risk, and the ability to be humbled and remind yourselves that this is a real entity with real bad outcomes. That is a life-changing event for me for sure.
That wasn't fair, Matt.
Sorry. We.
I guess I deserved it for springing it on you, but I think you bring something very real and raw there, and I want to stay here for just a second. These are people that touch our hearts, our lives. There's these patients that we come in contact with in these stories. And when you see it go right, you're so happy. And when you see it go wrong, you're so sad.
Yeah.
And we don't know. Dude, what did you do to me? You broke me.
Sorry. So, and you spend so much time with him, right? I knew him for years. Things were stable. Things were great. And it was wonderful. But it's humbling and a reminder of there are two individuals in particular under the age of 18 that, as you say, you develop friendships with them. For these to happen, it's like a family member for sure.
Yeah, it's harsh, it's cruel, but it's also life, and we're all trying to figure out how to manage it together. So it brings a lot of stress to not only the patients and the families, but our clinical providers. And I think sometimes we all need to take a pause and remember that the providers here, our clinicians, our nurse practitioners, our PAs, our MDs, our fellows, all of them that are taking care of us, they've got their own lives and their own experiences, and then they're learning about yours, and they're coming closer to your family, and the lines start to blend, because we don't do this for an appointment or a year. We do this over decades, and we develop deep relationships, and we know everybody. And when HCM tricks us, I don't know about you, it just pisses me off, and I just get more angry at HCM, and I want to find better ways to solve the problems, which has led to the last 30 years of my life being a little bit of a workaholic, but that's okay. We're all benefiting from it, I hope.
The good news is there's work to be done. The better news is that, boy, have they come a long way with experts like Barry and others, and who have really brought this to the front, right?
There are so many names and so much history. If you have not watched or listened to the podcast Cardiac Cowboys, it's not about HCM, but it really does explain, not that long ago, how cardiology was practiced and how we learned what we learned, and the rule breakers and the rule benders that created the rule books to keep everybody else safe. It's crazy. But we have that whole ecosystem here in HCM. And we have some amazing people, scientists. Some of them are they got some characters in the mix too. We got some personalities that are awesome. And we are a very interesting family. And we all play our part in the family. And we wouldn't have gotten where we are without the collaboration and the trying to understand better, and the academic challenges and the questions. And it's just been amazing to watch happen. But we're not there yet. We're not done.
Yeah, in no way, right? I mean, I think we're nowhere near there in awareness. We're nowhere near there in management as well. But that's the fun part, right? You continue to fight the fight, and little by little, we're going to chip away at the ice.
So you have a magic wand, and they say you can invoke a rule or a policy that will be mandated around the world tomorrow related to HCM. What would you ask for? What would you want?
I think
isn't it funny when people ask you what you want and you're like, I want it all?
Yeah. And so if I had a magic wand, I would remind folks that access to AEDs is the single most important way to protect anyone. And if we could have a magic wand, that I could have an AED and a plan to use it, and education on how to find it, I would do that, because the diseases are too tricky and you can't predict them well enough. And I'm not sure we'll ever get there. But the single best, if you're going to spend resources, if we're going to say we have to do resources, what's first? I would say making sure that people have an AED, that they have access to an AED, and that everyone knows hands-only CPR. I used to say you have to know how to swim, You have to know how to drive a stick, and you have to learn how to do hands-only CPR and learn how to and know how to use an AED. Those are the 3 life things you should know. I'm not sure the stick really qualifies anymore. The automatic cars, it's actually hard to find a stick these days. But I think this should be part of high school education. I think health class should require an understanding of what cardiac arrest looks like and how to find an AED and look for one. And it's not morbid. It's the contrary. It is how you can be part of the groups that save lives, right? There's nothing better if you can find one. And the alternative of that is worse, right? Not knowing what to do when someone goes down, it must be horrific.
Definitely. In our HCM awareness box that is available online for you if you want to have a home party, basically just cover the shipping costs and you can get all the materials, including our children's and adults' new bracelets. We've got all kinds of cute things for you this year. But it's an opportunity for you to put this up and talk about this in front of, your coworkers, a sports team, a PTA, a family, wherever you want to talk about it. So Matt is now walking.
Sorry, I'm moving.
If you're getting dizzy, don't worry about it. So he's moving location now at FIFA. So if you want to do a house party and you want to talk about your HCM, we have the tools to do it. So we've just dropped the box in the comment box below, and you can just click on that and we'll send you the package. And in that package is information about how to do a drill Dr. Heart. And that is an emergency action plan for your workplace, your home, your sports team, your school, whomever. It teaches you the steps. You want to build muscle memory in this skill. If somebody goes down, you don't want to be like panicking, like, what the hell do I do now?
Yeah.
You want to say, okay, I'm going to check for a pulse and breathing. Let's see if they're conscious. Okay, they're not. I'm going to call 911. While we're calling 911, we're going to see if there's an AED locally. If 911 is the closest AED you've got, that's the closest AED you've got. So you got to start hands-only compressions if that person's not breathing. But if you don't know that these are the steps and you're panicked, you're not going to remember them in order. And you might run around a building looking for an AED without calling 911 first because you're panicked. Have a checklist. Practice it with your team, your peers, your family. What do you do in the event of a cardiac arrest? And if you have the AED there, how to get that, how to use that, knowing your liability, knowing that you're safe from harm personally from using the device. And most states have Good Samaritan policies where if you try in good faith to save somebody, you are held harmless. So don't be afraid to get involved. I am unaware, Matt, you can correct me if you're aware of any successful litigation of anybody who has attempted CPR on somebody. There's no such thing.
No,
It doesn't. So do it.
right.
And
Lisa,
you don't have to do breaths.
I'm going to lose you because they're going to kill the Wi-Fi. Then I'm going to jump back in a little bit. So keep going. I apologize.
Okay. So we're going to talk for a minute while Matt goes off screen. That's fun. Okay. So I'm going to pull him backstage and I'm going to be on stage for a little while with you guys here. Wow, that's really big. I'm not used to doing this large screen. So while we're waiting for Matt to get his Wi-Fi back at FIFA, that doesn't sound a little bougie, doesn't it? So we're going to wait for him to come on back and he'll be answering your questions. Now would be a great time to pose any questions to him. Remember, Dr. Martinez is a sports cardiologist and HCM specialist and can answer any of your questions in a general fashion today. So I've never had this happen before where I've lost somebody in the middle of a thread and had to come back. So I'm going to riff and I'm going to go back to a podcast I did yesterday. And if you did not have an opportunity to see it, I would encourage that you do so. I spoke to Mary Mazzy. She wrote this book, The Little Boy with the Big Heart, in memory of her son, Will. So if you have not seen that yet, Demi's now shuffling for that Amazon link to drop in here. We are going to try to get some of the copies of the book in our store over the next couple of weeks, and you'll be able to get them straight from us. But for now, you can get them there. And we can also drop Ella's link as well. Ella's New Bee is a book about a young lady with HCM who had a heart transplant, and it's her own experience. And we're really proud of her for documenting it. And she was with us a couple weeks ago on podcast. So we would encourage you to take a look at that as well. And if you have not done your intake call with the HCMA, I'm going to turn this into a little commercial for intake and navigation. So here at the HCMA, we've provided a one-on-one service since our founding that You can call us, you can let us know what's going on with your HCM, and you can ask us any questions, and we can help develop a navigation strategy for you and your family. So, as part of that, the intake call is a really integral part of that. But we encourage you to do your intake call when things are calmer, not when you're in the middle of trying to make a decision and there's a lot of pressure on you. HCM is a long roll. When you're feeling up to it, you call, you do your intake, we engage you, we make sure we answer all of the questions that you have. You get a follow up call with a nurse navigator or soon to be a PA navigator. And that call can answer your questions. Maybe you just want to ask a question in a way that maybe you're not comfortable in asking in the doctor's office, and maybe we can give you some guidance on how you can rephrase that or be more comfortable asking the question. Some people don't want to ask their doctor about certain parts of their personal life, and they want to know if it's normal or not, and we'll talk to you about those things. Can I have a normal life with an ICD? Can I have a normal sex life with HCM? These are questions that, believe it or not, we get every day here at the HCMA, and it's okay to ask the questions. So the intake and navigation call allow you that opportunity to share a little information so we can help guide the journey in a personalized way. We then connect you with our Nest education system, which are learnings that you can share with friends and family or just use for your own knowledge about the HCM journey and why we do MRIs and what genetic testing is, and lots of different information and updates on that information as it changes. Been doing this work now for 30 years, guys. The world does not stay static. It is constantly evolving. There's new technology for home monitoring, new drug therapies, new clinical trials. It does not stop. Trust me, it does not stop. So we can get you involved in intake and navigation, and you can let us know. Please let me know when an open clinical trial happens in my area. Please let me know when you're having your next webinar or podcast or whatever. You choose the journey. Kind of feel like the movie Big, where it's that, remember the magazine at the end where you got to choose your journey? It was before computers were a thing. And if you're really young, you have no idea what I'm talking about, but that's okay. All right. So Matt has not come back yet, and we've lost him for a few minutes, which is not fun. And nobody's asking me questions today. Somebody better ask me a question. It's more fun that way. Okay. So Demi's popping some quotes in there. There we go. So let's talk about HCM Awareness Day and some of the things that are coming up. All right. I might be dishing on some things a little ahead, but you've seen some of the images coming up. So this year on HCM Awareness Day, we're going to start a new education concept. If you've seen the movie Inside Out, we are turning HCM inside out. And we are going to open up a dialogue about all of the emotions attached to being diagnosed or living in a family with or caring for people with HCM. And no matter your place in the ecosystem, whether you're the patient, the parent, the spouse, the doctor, the industry rep, the pharmaceutical rep, whoever you are, you have a place here. And you're going to see all these emotions play out, as you just saw with Dr. Martinez. That made me cry today. You got to go back and watch the beginning of this. Oh, there we go. That's the big heart. I don't know what happened there. So, oh, you're going to pull up the other ones, the other guys? Pull up the emotions. Okay. I'm talking to Demi backstage. So she's going to pull up our new characters. So Mr. Big Heart has some friends now. Mr. Big Heart has a whole family of emotions. We have joy and hope and anxiety and curiosity and sadness and frustration. And we have all of the emotions. And we're going to take some time over the next year to dive in deeper to each one of these characters and really unpack what that means to each one of us. I can tell you that I have been angry at HCM a lot in my life. A lot. This organization was built on anger, but anger can be really empowering. So, okay, Demi, that looks good. Why don't you share that one? So here are some of our characters that you're going to come to know over the next year. Joy and disgust and anxiety and anger and grief and hope and sadness and curiosity. My favorite is curiosity, because that curiosity kept me digging and digging and digging and trying to find answers. And somehow we built a whole community for everybody here. And some of you are feeling sadness, and many of us are feeling grief. And we don't have to feel things one at a time. Sometimes they come in together. And lately, with all of the changes in HCM, there's been a bit of joy and hope that I've never seen before. So I hope that you stick with us on HCM Awareness Day and start the journey with Inside Out HCM or HCM Inside Out and start to really think about how all of these emotions intertwine, not necessarily, well, let me rephrase that. Your whole life is impacted by HCM, whether you want it to be or not. If you have been just diagnosed, if you have been diagnosed for a long time, it's always in the back of your mind. Never goes away. Doesn't have to. It doesn't have to take forefront of your mind, but we are dealing with different emotions. When we feel bad, we might get anxious. We might get angry. We might feel disgusted that we're not able to do the things that we want to do. That might make us sad. But we may change our meds and get curious about a clinical trial or be willing to have the conversation about your real symptoms and what you're really feeling instead of saying, I'm fine all the time, and have that conversation with your chosen healthcare provider that brings you that hope that maybe makes you feel a little joyful again. So that's part of it. The other part is we just live our lives and we have the opportunity to have our families around us, which brings us joy. And we're curious as to what's going to happen next in the world. And we stand by and we wait to see where healthcare is going and where science is going. So there's so much to unpack over the next year. And there might even be some other materials coming out with these characters that I hope that you all can enjoy. I'm going to check my cell phone and see if Matt is talking to me here because she's been offline for quite some time. And I want to, oh, he didn't say he's not coming back. So we're going to keep rolling. Okay. So, Demi, why don't we pull down that slide and we can get into talking a little bit more about what's going to happen for HCM Awareness Day here in the office. So if you're going to come join us live in the office, if you're in the New York, New Jersey, Connecticut area, you want to take a drive down in the afternoon on February 25th, you can join us in the office and we're going to talk through some of our programs. You'll meet some of our staff. If they're not here in the office and they're virtual workers, they'll be on a computer somewhere where you can chat with them. You can learn about upcoming projects and where we're going to be building out our patient registry and what that registry will do over time with the power of the patient experience. We'll be talking to you about all of our meeting opportunities coming up in the year, how you can get involved as a volunteer, and what you can do to help the Children's Cardiac Safety Act in your state get passed. So, just as a reminder, the Children's Cardiac Safety Act is a group of policies, going back to what Dr. Martinez said earlier, that will provide AED, CPR awareness and training. All that is the foundational aspect of what we're trying to do. But specifically, we want well child examinations to include heart health history questions at every interval. We know that in most states, the utilization of the well child exam is over 70%. And if 70% of people are being asked the question, is there a family heart health history? What is the history? What are the child's symptoms? And the doctors are trained to look for these hints. We have an opportunity to get people to diagnosis in time. Now, most of us who are watching here know that just getting to diagnosis isn't enough. Getting to proper care is the next critical step. And if we can't build that arc from primary care or pediatrician to cardiology, and then the family connection to cardiology, we're never going to get the opportunity to make collateral differences in the lives of those with undiagnosed HCM at this point. So we're taking a big bite at the apple here, and we're trying to change some laws so that every well child examination and every child in America has the opportunity to have their family heart health history reviewed, not just athletes. Athletes are important, and we want to do good pre-participation screening physicals as well, and that's part of the Children's Cardiac Safety Act. But not all children are athletes, but all athletes are children. So we want to take care of all hearts. Sherry's bringing up a point here. Let's bring that to the screen. Frustration. Oh, we're back to the characters. Yes, is frustration one of the characters? It might be. I don't know. Demi's looking like, frustration. Okay. Tried to join a clinical trial, but due to the qualifying, you can explain some of the reasons why that would happen. I get the impression I'm not affected enough yet. So, Sherry, that's a great question. And I really thank you for bringing it up. So, let's talk about inclusion criteria for clinical trials. Sorry, I'm not used to doing all the talking by myself on this thing. So, what you need to prove in a clinical trial is that there's been an improvement with the therapy. So if somebody is mildly symptomatic, it may not be significant enough to show up in a measure. Your symptoms may not be bad enough to show up as a negative. So you can't fix the negative by making it a positive because you can't show the negative yet. This comes up with um, VO2 max. So when they do a treadmill test and they put the oxygen mask on you and they measure how much output you're getting, typically trials want people who are 85% or under predicted. So if you're managing well and you're 87 to 90% of predicted, that's still not 100% of predicted, right? So there's a deficit, but it's not a big enough deficit to measure the improvement of the clinical trial. So they may want that number to be lower so they can show a better improvement. That's that is a layman's plus edition of what that would mean. So I would go back and ask the people that you were going to be in the trial with, where didn't I qualify? And it's kind of awkward to say you don't qualify for a clinical trial and be like upset about it because you're not sick enough, but you really want that opportunity. And that, Sherry, I think is where the word frustration comes in. Like, but I want to try. You can't because you're not the right patient. This happened a lot in the non-obstructed population during the myosin inhibitor trials before we opened up any trials for the non-obstructed or any meaningful spaces. So the non-obstructed people felt pretty ignored for a while, and there was nothing there for them. There are 2 clinical trials for non-obstructeds right now, and there's other clinical trials for obstructeds. If you wanna learn more about them, you can call our intake line and set up an appointment and try to get that done with them. They'll tell you the trials and if there's a spot near you. Even if there is not a spot near you and you're willing to travel, let us know. As trials get a little aged and if they're having a hard time populating them, then they'll start putting in travel stipends for further distances. So if you had to fly in, for example, once a month to do something, they might pay for that. So that's the clinical trial question. So I'm sorry to say, but it doesn't look like Matt is going to be bouncing back at us. Let's give him another minute, see where he is. You coming? I'm going to ask him. I'm sorry. I'm trying not to leave dead air because podcast dead air is awkward. And he's probably trying to find internet, is my guess. But we'll give him another minute or so and see if he comes back and joins us all the way from FIFA headquarters. Oh, he's texting. What does he have to say? I don't know. The little 3 buttons. They're trickling. We're doing the thing. I think I might call it in a minute. Okay. Oh, what do we have here? Lorelei, my granddaughter can't get genetic testing because we're told that our TMP1 is not a good indicator for HCM. They tested my brother and he's positive. Okay, he's gonna be back in 5 minutes, so I'm gonna keep chatting here. Lorelei, I that's a tough one. Can't get genetic testing. I'm not sure who would have determined that if it is a pathogenic mutation. So if it is a variant of uncertain significance, then it would have little value. If it is a pathogenic mutation, it would have more value. And positive isn't a word I can work with. So is it positive for a VUS or is it positive for a pathogenic? That would be your starting point. And if it runs in the family, I'd be going out and getting a second opinion on who would genetically test a child in that pathology line. TMP1 is a mutation that has been tied to HCM, but is not necessarily what we would call one of the larger players. It's probably 1% ish. It's a very small percent, but it's real. It's in the right region. It can cause disease. So we have the opportunity to maybe test this child. I would keep digging into it. And if there's anything we can do at the office to help you find those providers, happy to help you do that. It does sound a little odd to me. So something's missing in that picture. So let's figure out what that is. He says he's going to be back in 5 minutes. Orlando. Okay. So Lorelai, give the office a call after this afternoon and let's see if we can't dig into who's saying what now. I love that podcast. Have you ever listened to Who Said What Now? She's a great historian, sociologist historian, if you haven't watched that one. I'm going to be like other podcasts shouts out today. Again, Cardiac Cowboys. I'm just on a rant today. It's Heart Month. It's my heart anniversary. It's 9 years. We're celebrating, we're memorializing, we're grieving. I find so many mixed emotions in this month, which is kind of why I like the HCM Inside Out concept, right? It's one of those things that you love and you hate and you hate and you love, and it's complicated. It's complicated. You are very welcome. We are very happy to be here doing all this work and trying to solve the problems of the HCM ecosystem. I have some really exciting things coming up that I'm not allowed to, well, I guess I'm allowed, but I don't think it's ready to announce yet. There are some new opportunities coming to us internationally that could be very exciting and help us reach millions of other people worldwide with HCM. These earrings were made by one of our members, and she is currently selling more heart jewelry as a fundraiser for HCMA. This was the first year she did them. They're all handmade, and we can probably get a link up there for her as well. Rosemary does these, and she does a beautiful job. So you can buy them online and proceed to help support the HCMA. Demi, you want to pull up here? I'll pull this up. Other thing we can talk about while we're waiting for Matt to come back is if you haven't got your, we can go to slideshow. There we go. If you haven't got your HCM awareness frame yet, Demi, who is sitting in the back right now, if you send her a photo, we've gotten over 300 frames so far. Wow, Demi, you've been busy. Thank you. So if you want to, let's try to get that number to 500 by the end of the month. Let's try to get 500 frames out there. So send in your photo of your choice with your awareness, and then Demi will send it back with your awareness frame, and you can make it your profile photo for the rest of the month during Heart Month on all your social medias. And you can passively help educate about HCM with just a frame. Sends people to the site if they, want to look up HCMA, and then come to our page and they can learn about what's going on in your life at a deeper level. And maybe your family will start to listen, and maybe somebody will get screened, and maybe we'll have the opportunity to save more lives. Okay. Still giving Matt his 5 minutes to come back. So that's kind of fun. So I want to go back and talk about the podcast I did. God, was it yesterday with Mary or day before? I want to bring this back because Matt said something earlier about ICD therapy. And if you go back and you listen to Mary's podcast, there is a real big cautionary tale in here for the community. I'm going to tell the story again in my words. You can hear it in hers directly. If you go back to the old podcast, her son was genetically tested. We knew he carried a gene. At 33 years of age, he was screened, and his heart was deemed to be normal. For reasons we will never know, 100%, he did not get any additional screening, which is out of step with the guidelines. He should have been screened 3 to 5 years with the gene positive and the family history he had. He was told not to. At the age of 41, he suffered a sudden cardiac arrest and passed away. Knowing your genetic mutation and knowing your family history, you really should be going for regular exams. We don't know the cutoff age of when you can stop screening in a genetic family, but we know that you need to keep going through the 30s, 40s, and 50s. And after the 50s, there's some controversy and some question now. Is over 50, do we still have to screen if we've been screening serially through that family? We don't know the cutoff age yet, but it definitely wasn't 40. It was definitely beyond that. Some people say over 65 you can stop, and other people say don't ever stop. And some people say after 50 stop. So we're working on the science of when to stop in a gene positive family with multiple serial echoes. But tell that to a family who's buried a 41-year-old. That, what time should they have stopped screening? So we have to get the message out to the cardiology community, not our specialists. Our specialists know what to do, but the general cardiac community, does not necessarily know how long they should continue to screen, and they're giving maybe misleading information, or a patient chooses to hear, I don't want to do that, or I don't need to do that, it's not required. You never know which way that story goes. And it doesn't matter at this point when somebody's gone, but we do want to make sure that we tell the tales of people like Will so that you and your family can stay safe and whole. That is the ultimate goal. Okay. He's trying to log on and it's not working. One more time. So funny. This is an awkward podcast. So we're just sitting here having a chat. How y'all doing? I hope it's all great. He's having a hard time getting in. Any luck? You know, we're just texting it away while he's backstage. So if you have any questions for Dr. Martinez, now would be the time to post them, because when he comes back, we're not going to have a whole lot of time. So let's get those questions in, and I'm going to give him like 3 more minutes, and then I'm going to stop giving my PSAs for HCM. Although this will turn into some nice segments for clips for advertising programs in the future, guys. So this is life in HCM. We just pivot along with the world. We don't get angry. We don't get flustered. We just pivot our way through. That is the way we work. Okay. So, Lorelai, I expect to hear from you. Sherry, I hope that you find a trial someday that is right for you. And I appreciate you even thinking about it. And I've got 3 little dots floating on my cell phone right now. Still floating on my cell phone. He says he's getting on. He's coming back. So ask your questions now. Make him feel missed. Okay. You could ask him anything. Good, bad, or indifferent. He's getting on. You know, my spidey sense said this one was going to be a weird podcast today. I got to really trust my spidey sense. Spidey senses are good. So here are the nails for the month. The pinkies are my green nails for my transplant. The whites are in honor of all those living with HCM, and the black nails are in memory. So if you're watching in a podcast, then you saw that. If not, you got the verbal. Who knows? He says he's getting on. I'm looking backstage. I'm not seeing him. Okay. I think I'm going to call it. I'm going to give him 1 more minute. It is 11:43. He says he's getting on 2 minutes ago. Who knows, my friends? Who knows? We can't be perfect every day, and this day doesn't look like it's in our favor. So, other things that you want to know about. Don't know. 9 years with a transplanted heart. Let's take a minute there. Somebody asked me the other day what I knew about my donor family. And I told them I knew that she was 32 years old. Her name was Brandy, and her sister's name is Mandy. And Brandy had a daughter. That is all I know. If, by any chance, Mandy is watching, or we can get this to Mandy, because God only knows where Mandy is, I'd love to have the opportunity to meet you someday. Brandy and I are getting along very well. And she is a beautiful heart who has helped me do amazing things. And I am incredibly grateful. I know there's been a few of our people waiting for quite a while now for hearts, long waits. And those waits just seem to be getting longer nationally. There's been a little bit of controversy lately over organ donation, and this happens every once in a while. Didn't really plan on doing this today, but why not? Matt's not here, and I just get to talk to y'all. I think we, the collective, we in the transplant community, patient, providers, OPOs, UNOS, everything. I think there was an opportunity to do more work in educating people about what a deceased donor is and what this new process is going to be. Hey, Matt, welcome back. Thanks for coming.
All right.
Sure,
Sorry,
this is great.
they tossed me. So I had to switch venues, but all right, let's carry on.
So let me finish up my thought. I was going on a transplant route because, you weren't here and I was going on a rant. So what I was saying about organ donation numbers, they're going down a little bit in the country. People are waiting longer. And there's been some concern over this. There's been a couple of investigations of OPOs around the country with some pretty salacious claims. Um, I don't necessarily know that I believe them. Their claims. I haven't seen the proof yet, and when the receipts are out, I will look at the receipts and see where the problems are, and we'll communicate that. But okay, as a patient who has received a heart transplant, as a family who has donated the kidneys and liver of my sister, as the friend who has donated cornea and bone and tissue from other friends who've asked my input, I believe in the process, I believe in the science, and I believe in the ethics. If somebody has done something wrong in that process, they should be held accountable. But that's not the system. That's the exception. That is not the rule. And please don't let a bad actor stop your family from making a decision that would give your would donate organs to save somebody. We're throwing things away, body parts. We're just letting them go when there could have been an opportunity for donation. And I know it's a really heady concept for some people, and for some people, it's just not the right thing to do. But for me and my family, it was the right thing to do when we donated, and it was certainly appreciated when it was there for me when I needed. So, um, for anybody who wonders, like, you want to know what it's like on both sides, ask me anything. I've been through the process multiple times. It's an amazing, terrible process, but it also is inspiring. Zach, let's see. Appalled by harvesting. I was like, I'm appalled at the lies out there that harvesting organ and killing people. Yeah, there's a lot of them out there. And harvesting was a term that they used to use, and it sounds cruel. It sounds harsh. It's a terrible word. Procurement is the word that I choose to use, and most people will choose to use that you're going to procure the organs and prepare them for transplantation. Every person that I know that has been involved in that process treats everybody with respect, mostly the donor, and they are revered and they are treated humanely and compassionately. And that has been my experience. I'm sorry if you've had another one, but that was my experience on both sides of this. It was just an awesome human connection experience.
Yeah. And
So,
as
Matt, welcome
somebody,
back.
well, thank you. And as sorry everyone for having to do this. I do this to Lisa more than once, so I apologize for that. As somebody who has helped um, on the delivery side, having discussions with folks about whether they should or they shouldn't, uh, they, the families of that and those individuals, I think, get a lot of closure and a lot of joy from that. And I think if you're considering it, you think it's the right thing for you, you are changing lives, not one, right? Usually many, 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 many lives with depending on how much you're able to donate. So amazing, amazing opportunity to um, kind of honor your loved one with a final gift that they continue to live on.
Absolutely. Dominic, your question was, what is the current thinking around HCM hearts and transplants? If there's a thought that HCM hearts should be given a new look and get on transplant lists sooner before the other organs are affected by our bad hearts. Okay, Matt, let's talk about advanced heart failure and HCM. When should somebody with HCM talk to an advanced heart failure program?
If you've got non-obstructive HCM and you're having ongoing symptoms and you're intractable, where you're having breathlessness and exercise intolerance, or you've got a rhythm problem that is intractable, we can't control the rhythm. My rule, their rule is earlier is better. I don't mind the phone call when they call me and say, were you thinking soon? No, I wasn't thinking soon. I was thinking they needed to talk with you and get in the game, and you're going to remind me about all the things they need to do. I don't do transplant, but I know enough to involve a transplant expert soon and then have a conversation with them about it. There's a lot that goes into it, right? They have to be evaluated. It's more than, are you ready for the heart? It's, Are you ready to receive the new heart? Have you had all your vaccines? Have you had all of your cancer screening? Are you having some of the counseling that goes with this? And I think that process really helps. And the sooner you start it, the better. No one wants to hear this conversation. Usually it's further off from the patients I have, but I know that when they're sent to me too late, I am much more regretful of that than I am of sending somebody early and having the transplant team say, send them too early. If you're having symptoms and the doctors we're running out of therapies for you, right? In non-obstructive HCM, at least at present, our therapies are limited. We're using other therapies for other diseases and kind of retrofitting them into the non-obstructive HCM. That may change. We expect maybe in the near future, and as we continue to focus on this. But if you have intractable symptoms or rhythms that can't be fixed, that can't be controlled, this is the time for you and your doctor to start to think about this as a next option.
Let's talk about EF. So we don't talk about ejection fraction very often here because it's not typically our problem.
Yeah.
Can you first explain to our listeners what an ejection fraction is, what HCM normal and HCM abnormal looks like?
Yeah, I think in the old days, we used to think about an ejection fraction as either being normal or low. And in HCM, they break that paradigm, and other diseases too, amyloid as well. So an ejection fraction is literally the amount of blood that your heart is squeezing out with every pump. So we think that the heart would be 100%, right? That it squeezes every drop out with every squeeze, but it doesn't. It's more like a normal, we typically say, is somewhere between 50, for a normal healthy heart, somewhere between 50 and 65. If you're a high-level athlete, you get down to around 50, maybe upper 40s, but certainly not below 45% in rare exceptions. HCM is usually an over-squeezing heart. It works too hard. So it's squeezing typically between 60 and 80%, 75%. If you look at the trials for the myosin inhibitors, all of them, the average ejection fractions pre-drug were about 74, post-drug somewhere between 60 and 65, 68. So the HCM hearts are higher than everybody else. When they start to dip below 50, we're in trouble, right? That's a bit of a rarity in this condition. 3 to 5% is what we typically say. And it gets below 50, we worry about risk for cardiac arrest. That should be a conversation about a defibrillator. It is when it continues to dip down, this is the time when you start to use advanced therapies, and that's when this conversation about heart transplant is. One of the challenges with ejection fraction is how do you measure it? And we can do it with an echo most commonly. MRI is probably considered the most reliable, the most reproducible measure. You can do it with heart cath, you can do it with a nuclear scan, but echo is clearly the mainstay for this. But our ability to measure it, 5 people look at it, different measurements, we can get very different numbers with that. So ejection fraction, when they go under 50, that's when we should all get a little more nervous.
So let's say somebody's been hovering at 50, 52, 51, 53, and they're just hovering at that borderline. Like, how accurate is that number? And could it really be 47 or 45 or 55? Or what's the predictability of how solid that number is?
It depends on how you measure it. We'll say for echo, it's somewhere between plus or minus 5 to 10%. So that 50 could be low 40s and that 50 could be mid 50s. So that when you're getting on that border and you're trying to make a decision, MRI is absolutely the next option. And that's going to be more reproducibly measure that ejection fraction. Is it more correct? That's a complex answer, but it is more reproducible. If we do an MRI and 4 different people review the MRI, they're going to have closer numbers. You might say 52 and I might say 50 and somebody else might say 54. So they're much more narrow in terms of separation.
So I'm encountering new problems because as time goes on and therapies evolve, people move on. So back around 20 years ago, we were putting in a lot of ICDs for the first time, and people were getting deviced up in the late 90s, early 2000s, and these hearts are now maybe not doing so hot. It's been 30 years plus of therapy, and maybe they're heading, like I did, down that transplant path. but they've got a lot of wires and a lot of old device in them. Can they use MRI respond? Like, is it really going to work for them? Is there going to be dropout from all the wires? Like,
Yeah.
what happens with that?
So in general, we would say most of the time. So it's not like the old days we used to say no MRIs for anybody with a device. And the newer devices are generally considered safe, but as you mentioned, sometimes the leads are unsafe if they're coiled too much, if there's too many leads, and then where the device is on your chest. If it's slipping down and landing over the heart, if you've got a subcutaneous defibrillator, it's often sitting right over the heart. So when the MRI tries to shoot through it, it gets blocked and it leaves like a black band that goes over the top of the heart. So this is a good conversation with your clinician, the cardiologist sending you for the MRI, and then any MRI program that's doing cardiac that's really worth its salt is assessing that. Where's the device? Is it going to overlie or not? But to your point, I mean, we know that we've been pacing people, and the when you pace the right heart, which is where the device is sitting, too much, the heart doesn't like that, and the HCM hearts in particular don't like it. So sometimes we have to add another lead to help the other side of the heart. So all of those are conversations with your expert.
So I know what I do in the space of navigation. I think talking to people is really smart. And I think talking to people earlier rather than later is smarter. So when somebody's EF is hovering around 50 and it hasn't gotten any better with all medical optimization, and we really can't expect it with therapies we have right now to get better, can we?
No, I mean, it's, certainly in general, you're going to see a bump when you start a new therapy. But if you're maximized, we would expect the ejection fraction to go down, stay stable in many scenarios, but it's unlikely to go up once you're on good, heavy, adequate goal-directed therapy.
So as we're thinking about this complicated path for maybe up to 5% of the population, having a conversation, if that EF is floating around 50, looking at the whole patient, the family history, the genetic background, and then setting a plan with HCM plus advanced heart failure
Yeah.
to work in parallel for a while until it's time to hand off. And if it doesn't come, if you don't ever get that sick, you don't use it.
Yeah.
And then if you do need it, you've already done all your pre-work and it's okay. Yeah, now it's time.
Yeah.
Listing times have elongated. So
Yeah.
I only waited 71 days on the list. That's not common today. People are waiting 6 to 12 months.
Yeah.
So you don't want to get there too late because you might not have the time.
Yeah, and you may be a unique case, right? Depending on your blood type and other parts of your history, you may actually be easier or you may be worse. And then, the place that you live will have impact on how many hearts are available. If you've had old cancers, if they've been therapeutic or not. But again, a early review and a evaluation for your functional capacity, we call this a metabolic stress test or a CPET, a cardiopulmonary exercise test, where we measure your functional capacity. I like to see that trajectory. It was here, then it went here, then it went here. And I think from a patient standpoint, it also helps you wrap around it, right? That you
guys have to watch.
Right? Objectively, we're declining. And it's not in your head, right? Things are getting worse.
So going back to my life, my transplant, I had gotten on a clinical trial and I'd got my VO2 up to 21. And I had always been like an 18 and I maximized and I went up to a 21 and I was psyched. I'm like, I'm getting better. And then whatever hit me. I went back to a 17 and then I was a 13. And that 17 to 13 happened fast. And I got pathwayed properly. Thank God I got there in time. But I don't want people to miss their opportunity to have the conversation, to evaluate their individual risks with their individual team, and move forward appropriately for them.
I think that's right. And again, from a patient standpoint, it's still your choice, right? No one's forcing this. But I think the sooner you get there, the more chance you have to start to think through this and decide if it's the timing is right or not, right?
And Mint Brain is commenting you could stay that way for years. It could stay static for years. There is data. It's an older article by Barry, and it talked to EF, time to transplant or death when the EF goes to 50. And that paper said 7 years. I found out my EF dropped, and 6 years and 6 months later, I had a heart transplant. So sometimes statistics play out nicely, and I'm the bell curve, but there are people on either side of that curve as well. You can
Yeah,
fail
and
fast.
medical therapy's changed, right? So we have more advanced therapies than before for that weakened heart muscle, but they're not HCM specific in any way. And then the other benefit of repeating an MRI in some scenarios is looking for scar. That may end up telling you you're in a worse place.
Okay, I'm going to pivot the conversation to a theoretical conversation that might have some bearing in recent activities. So let's say somebody got a device put in 23 years ago, and they experienced a lead failure or fracture.
Yeah.
So this has played out in my family. I've been given permission to talk about it. Give a shout out to Stacy. So we had a fractured lead in the family, and we had a lead extraction, and we have a new device. And I have been giving a great deal of thought to aging leads and whether or not we need to start talking about some old school things that we haven't talked about in a while. And that's having a magnet at home for device failures. And it's an ounce of controversy because it's hard to travel around with a magnet all the time. Your magnet will wipe your phone, your credit card, your computer. You can't live traveling around with a big magnet all the time. So there's that functional capacity issue.
Yeah.
But when a lead is getting aged, is it a wise thing for a patient to ask their doctor, in case of lead problem, should I have a magnet and how do I use it? Is that a reasonable conversation, Matt?
It is. And I also would ask about the leads themselves. We know that there are some leads that may have a higher propensity for breaks. As you recall, there were a bunch of recalls in the past. And for those who have devices, in general, these are pretty sturdy, right? They do generally well. If you think about the total volume of them implanted, they do very well. But they're not perfect in any way. And I like the idea of having a magnet. I like the idea of knowing what some of those telltale findings are. And the individual you just mentioned, I cannot confirm or deny I know anything about what you just said, but if it was positional, leaning forward, moving your arm up, and that's what set the device off, change in position, that's a sign that this is likely related to a lead fracture. And a lead fracture is what you might expect, right? It's a lead like any other wire, and it's got insulation around the outside of that lead, and it cracks. And then the connection's good, then it breaks. And the device says, something's wrong, I'm hearing noise, or I'm not getting the communication, you must be in trouble, and it shocks you. Yeah. And it shock you and shock you and shock you. So having that magnet at home will stop that trauma.
So Lorelai's asked the question, and the magnet. So my home has had a magnet on the very large magnets on the refrigerator per device, and I asked for it. Stacy was part of a recall at one point. She was given one. I got one for my daughter because she had inappropriate shock. So we each have magnets. So the person with the device is the only one that can use the magnet, and you hold it in place. Because if you're holding it in place and you have an arrhythmia and you pass out and you drop the magnet, the device will go back on. So EMS can't hold it. Your family member can't hold it. You can't tuck it in your bra. You can't tape it on you. You have to hold it and wait for EMS to come or get to the emergency room where they can turn off the device and they can assess what's going on. And that's how you can stop inappropriate shocks. The alternative, we were advised by New Jersey EMS, is we would have just given you fentanyl and knocked you out while you were getting shocks.
Yeah.
So I think a magnet is probably a little less invasive than knocking you out with fentanyl and then not having you be able to communicate. So, hi, Stacy. It's me. Yes, it's Stacy. It is Stacy. My Stacy. She got shocked so many times. So scary. It was
Yeah.
not a good day. It was a reminder that HCM doesn't rest, and all of the collateral things that you have to do to manage your HCM are always there, even when you're not thinking about them, and you need a plan.
Yeah.
So I'm going to talk about catastrophizing. Matt, we've not had this conversation yet. I
Mhm.
can catastrophize anything in my brain and come up with a solution that if this happens, I'll do this. I've probably spent way too many hours catastrophizing a particular event, and that event is lead fractures because they scared the shit out of me in 1997 when I got my first ICD.
Yeah.
So I have thought, who do I go to for extraction? What is my plan? How do I get there? Who should know this? So I've always had a plan B, and I'm probably going to bring somebody online to have that conversation about what do you do if and how do you create your plan Bs? Because about 10 years ago, I said, I can't catastrophize anymore. This is not healthy. I have a playbook. I'll update it as needed, but I'm not going to continue to think about it. And when I got a call from my niece and she says, this is what's happening, playbook was there. I didn't have to stop and think, much like Drill Dr. Hart. I had some muscle memory because I thought about it. And I got to help her get to the emergency room, called all the right people, got things done, got her transferred to where the lead needed to be extracted right in front of a snowstorm. So if you have a plan, you don't necessarily have to enact it. But if you have the playbook, it's easy to pull it and you don't have to think when you're scared or concerned about somebody else's well being or worried that thare hurting. So you would have to ask your clinic, your ICD clinic. So we have another question here, another name you'll know. You're going to have to talk to your ICD clinic about talking to your device manufacturer about providing you with that magnet. Now, I may have just caused some problems for BMS, or not BMS, I'm sorry, Boston Scientific and Medtronic and Abbott, because people may not have known that this was a thing. But I think we need to talk about the thing because
Yeah.
having inappropriate shocks isn't nice.
Yeah, they're little donuts, right? They look like blue. The one I'm thinking of is blue, which like the
Yep.
size of a donut, looks like a donut.
Yep.
And you can get them from. I would ask your EP doctor, the person managing your device. They can help you with how to identify that. And there's another really good question about delete. This is it. Do leads get checked at each device? And the answer to that is yes. They're constantly being checked. So they're even when you don't know it. If when you walk by your home monitoring. If there's something wrong with the device, it will send out a signal. Um, so it checks the lead strength. It does looks for impedance every time you evaluate it. It tells you battery life. All kinds of things are being checked. They're fairly sophisticated. So yes, all that's happening all the time, but that crack can happen in an instant, right? That you fall, right? Fall on the ice and your arm stretches out and you crack it.
Or, and this is something that I've always been concerned with, and there's not a lot of great data on this, mammograms, old leads and mammograms. I just don't think it's a good thing for some people. I always refused, and I would do sonogram on the side where the device was. So if you have older leads, talk to your team about what is the safest way for you to get your breast exams and not interfere with the leads. I think when they're newer, it's not much of a deal, but as they get older, they do get more brittle, and you may want to give that some consideration.
Yeah, and the
Um,
devices are changing, as you know, sub-Qs and this EV-ICD is a newer version of this. So it may be that you just need to swap out.
yeah, and that's all you're going to need to do. At the very, very, very end of my heart, one of my leads started to alarm that it was impedance rate wasn't good. We just changed the impedance rate and ran it out another 90 days and it was fine. But it did alarm, and alarming devices don't necessarily shock you. They just let you know something's a little out of sorts. So that's the drama that we've been going through the last little while, and Stacy is still recovering from her new EVICD, and maybe she'll come and tell us about that experience when she's healed up. But we don't have a lot of people with HCM with EVICDs yet. Matt, you want to tell people what an EVICD is?
Yeah, so it's going to look a lot like a subcutaneous ICD, right? It has a similar uh, look to it, except it has a different way of running up the opposite side of the chest wall. It can be a little more uncomfortable. It's somewhat of a bigger scar. The benefit of it is that it's extravascular, right? So it's outside it's outside the bloodstream, so the infection rate is lower. There are some benefits with this ICD compared to a sub-Q, that it does have some pacing capability, so that it can. Subcutaneous ICDs will not raise your heart rate, where a EV ICD, it's not a pacemaker, but it has the ability to pace your heart out of rhythms and to raise the heart rate in somewhat of a different way. But we feel like this is an upgrade from subcutaneous, from original subcutaneous.
I like that the lead is closer to the heart. It's not over the breastbone, it's under, so it doesn't require quite as much energy to defibrillate your heart.
Yep.
So it should be less painful should you get a shock if you were conscious for it, but you really shouldn't be conscious. Lorelei, it sounds like you and I need to have a long talk. There's a couple things going on in the family that we got to help you sort through. And we can help create a plan for what is my emergency plan? Who are the people? Where are the higher lead extractors located? And if I need one, how do I get there? There are some programs that do lower volume lead extractions for newer leads, but the longer it's been in there, the more expertise you want getting it out.
Yeah, and you're sort of saying it without saying it. This is not something that is done by everybody. Really good electrophysiologists, experts in the world, things you've heard, people you hear from on a regular basis, they may not do it. So there are centers where folks say, I'm going to specialize in this and I'm going to do this unique procedure and spend some time really digging into it. So like everything else in HCM, right? Finding an expert for the thing that you want to do is doable, but it's going to require a little bit of work. And that's obviously where Lisa's wheelhouse is.
So Dominic, yeah, the leads have to come out from the old device before an EV-ICD can go in. I don't believe they can leave any abandoned leads in the chest because it may give artifact. So
yeah, and there are some other pieces to this, right? If your EKG has something like a very tall T wave, you may not qualify for it. So we don't want you to, again, you need to see an expert. There are some things that will eliminate you from doing that. Maybe you've had radiation to your chest wall before, breast cancer, surgeries, things like that. So it may end up being more challenging. It's not a universal fix. And this is a great time to talk to your electrophysiologist about it. These men and women, they love this conversation. They're new stuff.
So I do not have an all-encompassing list for the country on the highest lead extraction providers. I do have an East Coast list that is pretty short. It has changed over the past couple of years. So there's expertise at Northwell on Long Island, at UPenn, at Cleveland Clinic. Those are the highest volume extraction programs that I'm aware of right now that I've worked with over the years on the East Coast. I do know the volumes of lead extractions of all of our centers, and some of them are higher and some of them are lower. And some leads are easy to get out. And some leads have what they call double coils. And they're the really bitchy ones to get out. Ask Stacy. She had that kind. So when you have the double coils, which were used in the early 2000s, it's a little harder to get the tool in there. And even the expert center she went to had to use one tool and then abandon it and go in with a second tool, which thankfully they had. So they didn't have to open her chest, and it was all done through catheter-based procedures, and the leads are gone. So we will work on getting you some more information about lead extraction. I have catastrophized it enough for the entire HCM world. You don't need to worry about this. I'll give you the playbook. All right, now I'm going to let you head off here on Go Red for Women Day and Heart Month and all things fun. So thank you for joining us in this two-parted edition of Tales from the Heart from the HCMA, all the way from FIFA and Switzerland? Switzerland. Yeah, Switzerland.
Switzerland, indeed.
I like Switzerland.
Indeed. It's beautiful. It's beautiful. It's actually not too chilly, but it's a really neat little town to walk around. So I look forward to the next one.
We will keep doing this, my friend. You have a good Heart Month and travel safe. And thank you for joining us on Tales from the Heart. For those who came in a little bit late, you can go back and revisit the entire episode in just a moment.